this is something that is a top of mind right now, and we've really been looking more at these numbers and really are kind of internally as an organization and externally with our stakeholders trying to assess how do we contribute to achieving racial justice. And I think clearly we're familiar with the significant overrepresentation of communities of color inside our prisons and jails. But I think some of these numbers are really significant, and just you can read some of the details. But for example, Latinos and African Americans make up only 32% of our country, but they comprise of 56% of all incarcerated people. We also, I think at the bottom, this was a really significant rate that Native Americans, a small proportion of our overall population, are incarcerated at a rate of nearly 40% higher than the average. Let's see, and for LGBT, I think we're missing a letter there, and for LGBTQ, they're overrepresented 3 times in our jails and our prisons. And this was something I was just learning about recently. And it's really important when people are incarcerated to really have gender-informed and specific practices. Okay, next slide. So this is something that we're all familiar with when we're thinking about marginalized groups and people who have compromised behavioral health systems. And I think what's telling in this slide is, look at the substance use disorder box for jails. Nearly 70% of individuals in our jails have identified with a substance use disorder. That's significant. It's only slightly less for prison, but still, the comparisons to the general population is really significant. We clearly see a significant overrepresentation in our jails of people with substance use disorders, and a quite significant overrepresentation of people with serious mental illness. Okay, and these are some numbers that are specific, and these are, this is pre-COVID, so we'll get to a discussion about the impact of COVID in a little bit. But this is a nice slide that really just shows the concentration and the growing concentration of mental health cases in our California jails. I think this data is from, I think it actually is from like February, like right before COVID. But as you can see, a significant growth in the last even 5 years of the concentration of individuals who either are an active mental health case or who are on psychotropic medications in our California jails. And I think what's to me telling about this particular visual is that we know that when we are thinking about our jail population, if somebody has a serious mental illness and they're in jail, basically 2/3 of them have a co-occurring substance use disorder. And I think when we talk about solutions, this speaks volumes to the need to have better and more accessible and effective, frankly, co-occurring disorder community alternative programs where we have a seamless integrated delivery of both mental health and substance use disorder treatment. Next slide. So I talked a little bit about how frustrating this is because we know that there's so many negative outcomes associated with individuals who are in that intersection between the justice system and the behavioral health system. One of the ones that our council has been focusing on significantly in the last few years, and it's certainly because of organizations like yours and others that have really done an excellent job advocating for the need for more specific and effective housing services for our population. But again, also our concern that cookie cutter approaches to addressing homelessness don't necessarily recognize the complex needs and specifically the need for wraparound services that people with mental health challenges need in order to be successfully housed. So Of the 11 million people admitted to jail annually, about 15% report experiencing homelessness in the year prior to arrest. And while these numbers, I can't remember, these are numbers on the older side. I think in California we would find that number much higher, and I'll talk about it in a little bit. But no surprise that rates of homelessness, and we have data related to California in our last point in time count, that if you're an individual who's suffering with a mental illness and you have a co-occurring substance use disorder and you've been involved in the criminal justice system, you may make up as much as 30% of the unsheltered homeless population here in California. And we're still working through some of that data, but I think that's a pretty safe estimate. Excuse me. Next slide. And homelessness, like say unemployment or lack of attaining a GED or other outcomes, is one of those issues that you can directly draw a link to engagement or interaction in this kind of cyclical. And I think in the very beginning in our word cloud, someone said revolving door. As you see here, it's a nice visual that really documents this cycle that exists between homelessness, law enforcement, and the criminal justice system, and mental illness. So of course there are law enforcement policies and procedures that really increase the likelihood of arrest for someone who's experiencing homelessness. We're all familiar with, I can't even imagine how challenging it would be to be homeless, but the sheer act of homelessness in many of our California counties is going to and could be grounds for even arrest. So if you have lack of stable housing, this oftentimes in our criminal justice system is seen as a risk factor. So and we will talk a little bit about diversion, when courts are thinking about diversion or they're thinking about alternative custody models, somebody who doesn't have a home may not fare as well in that decision-making process to be eligible for diversion unless that diversion program has the capacity to provide them housing. So again, that seems a little unfair, but it also increases their likelihood that they may stay in jail. Again, we're not talking about zero bail situation right now, but we'll come back to that. Criminal histories, this is a real pet peeve of mine, and the council's been working on it for a couple of years, but criminal histories really still, even with improvements in legislation, really pose a barrier to getting housing. And many of you in your advocacy for your loved ones may very much experience this. And so it really contributes to housing instability and increasing the risk for homelessness. And then 4, lack of stable housing upon exit from jail really contributes to supervision failure and increased risk of recidivism. So I like to use this example when talking about kind of the layers of challenges that someone has when they have a criminal history and how it really increases your risk for having some of these other negative factors. Okay, next slide. And I think what I would say to my staff, if they're on the phone, if there are things in chat, I know that I see the chat box blowing up. I am not very good at multitasking. But if there are questions that people are asking that you guys might have the answers to or want to comment on, please feel free to do that. So I really am preaching to the choir here when I talk about why community alternatives are paramount, but I do want to empower all of you to do this kind of advocacy locally, and we will talk about that. But I think at this point it really is common knowledge, but it amazes me that it's not more of a priority, although there are lots of priorities, lots of competing priorities and lots of challenging times ahead with such reduced budgets. But we do know that people who have mental illness are much more likely to stay in jail much longer. And so really what that means, and I don't have those statistics in this slide, but individuals with mental illness are quite costly, significantly more costly to serve when they're in prison, and tremendously more costly when they're in the state hospitals than any in any community program that could possibly exist. So the challenges of incarceration really follow people home. And I think if you do have a loved one or you personally have experienced incarceration, you know this. You know that just because you're returning home, it doesn't mean that you still don't have a substance use disorder treatment need, or that you don't need attention for your serious mental illness. And we estimate between probationers and parolees that about 10% have a serious mental illness and need treatment. Individuals who don't get access to behavioral health services upon release have higher rates of recidivism. That seems like it would make sense. In California, the reconviction rate for someone with a serious mental illness is about 52%. And that's only 45% for the general population. But we'd have to ask ourselves, well, does that mean that we're spending more on trying to help people with serious mental illness upon reentry? I don't know about that. And I think this one's particularly sad. You know, 5 years after detention, the majority of youth had 2 or more behavioral health disorders. Oops, someone popped, I can't see the slide. Oops. And 70% of males had co-occurring disorders. So, apologize, just close that. Okay, next slide. Pay attention to the time. Okay. So what do we know? So that's all. Okay, so we made the case. The case is actually quite easy to make. But there is a continuum of care and services that are needed across both systems. I think something, when I came to this work after spending 15 years working in behavioral health, I really didn't know that there was a justice system continuum of care. And there really is, and it's different in every location. But I think that there is a possibility for these systems to integrate so that we're addressing both the risk factors to recidivate and the risk factors to become involved in the criminal justice system, as well as treating people's mental health and substance use disorder. We all know that behavioral health care and interventions in the community is much better than incarceration, and that's where we should be putting our money. And I think something that's really important is a shift in the criminal justice world. And for those of you who may have been involved in this work for a decade, I would say even in the 5 years that I've been doing this work, there has been much more of a discussion and shift about we need to provide services, not just supervision, and that reentry or diversion programs really aren't just about creating structure and making sure that someone doesn't stay involved or return to the criminal justice system, but it's really about treating the underlying health and wellness issues. And that's really what's going to lead to success. Next slide. So these are things that you all are familiar with. This is kind of our approach in mental health, and we've been doing a lot of education in the criminal justice space with parole and probation about really looking at all of these things that need to be addressed and supported in order to help somebody who has a mental health condition. And I think that you guys can look at all of those things, but it really boils down to, does the person have relationships? Does the person have hope? Does the person have a roadmap to what could be a better life? And it's not just about, does the person have symptoms, or does the person have, are they medication compliant, etc. It's really looking at, is this person really happy and supported in their community? And that means that we have to provide services that maybe we weren't used to providing, like good employment services, really important, opportunities to further people's education, etc. Next slide. So I mentioned this before, services, not just supervision. When folks come home, and you guys know this better than probably I do personally, is that people come home with very high rates of poverty, unemployment, and homelessness. And while I have been a huge advocate to say that public safety is a public health issue and public health is a public safety issue, I think this really talks to the fact that we're always seeking appropriate health outcomes. But if we don't address some of these other issues, we can't stabilize and help somebody in their recovery, long-term recovery from either serious mental illness or substance use disorder. So we have to address the poverty, we have to address the unemployment, and of course we have to address the homelessness. We know that there is a significant number of preventable hospital admissions from people who are directly coming home from incarceration, and that these are much higher if someone has mental illness. We actually have a research project associated with this where we are tracking this. And I think with everything going on right now, those numbers are just going to be higher. And the people themselves, people coming home from prisons themselves, really reported that they were coming home with a complex set of conditions. I mean, 6 out of 10 women reporting a combination of physical health, mental health, and substance use conditions upon reentry. Imagine being able to stay employed, get employed, etc. if you're dealing with all of those issues. Of course, you also probably are housing insecure. Next slide. So what works? We talked a little bit about this before. This is our mantra at the council. And if someone wants to talk about criminal justice, we're going to talk about healthcare, and we're going to talk about the need for services in the community. It does cost, on average, more than $80,000 to treat a person. That's actually just the average cost of someone in state incarceration in California. If that person has a mental illness, I'll tell you right now, that dollar amount is probably anywhere between $12,000 to $20,000 higher. Now that $22,000 of as the community alternative, certainly that would be a person who's on Medi-Cal, a person who might have some additional housing assistance. But generally speaking, we're talking about a significant, quite frankly, more cost-effective way to serve people. And the thing that we do know now is that if there have been some studies now that we've expanded Medicaid coverage, and they really have been, and being on Medicaid in our state Medi-Cal, and in this conversation, really access to the Medi-Cal specialty mental health services leads to a 16% reduction in recidivism. So that 52% rate that you saw before of people with serious mental illness reconvicting, I think we're really hopeful that we're going to see that trend go down as that population gets on Medi-Cal. And the big part, the big aha or challenge is actually getting to the door of a service provider. It doesn't do us much good to enroll you in Medi-Cal and get you into a Medicaid plan, or excuse me, Medi-Cal managed care plan, if we can't figure out how to get you into the door to services. Yes, keep going. So what needs to be done? Many of you I saw are from counties that are participating in the Stepping Up initiative. This is a picture you might be familiar with, but in my view, you can't solve a problem unless you dissect it and understand what the problem is. And doing sequential intercept mapping without having to do a whole, and I'm thinking when the Department of State Hospitals was here, they may have talked about this, but the long and short of this particular graphic is that in your county, this is basically an activity and asset mapping. When you're sitting down and you can get together in a room with law enforcement, the courts, your sheriff there, and your behavioral health providers, and potentially also other service providers, I think it would be important to have your county continuum of care or your public housing authority present, and folks that provide other essential social services, to look at what kinds of services are you providing in each of these intercepts. And the intercept, all it really means is it's the point of intercept in stopping someone from falling deeper into the criminal justice system. So for example, you see that intercept 5 really is about sustained community support once somebody is coming out of incarceration. And I think many counties have done this. And so as advocates, I would really encourage you, and we could work on this as a follow-up, to see if your county has done this, to read the plan and start thinking through what are some strategies to make improvements in areas where you've seen weaknesses? We've worked with counties to kind of map what funding source could help fill a gap in any of those areas. I apologize, I keep using my finger because when I typically use this graph, I'm standing in front of an audience and I can point out with my finger what I'm talking about. I apologize, but generally speaking, there's different funding sources that can make investments in this area. So for example, crisis lines in the crisis care continuum, a lot of Mental Health Services Act resources go towards that. How are those being used in your community? For this section over here on Intercept 5, where parole and probation play a really important part in helping individuals get access to appropriate services so that they don't re-enter prison or jail. How is that working in your community? Is your probation department working very closely with your county behavioral health? And probably more important, and the discussion we're going to have in just a moment, who is parole? Like, where is parole? How can you help play a role in linking people who are on parole to adequate services in your community? So a great tool, and we can do some follow-up on that. So what needs to be done? These are areas in which, you know, it's kind of, well, we think it's a little bit common sense, but these would be kind of the 4 things that we feel would be essential if we were really going to do behavioral health system transformation that had an eye towards reducing incarceration and recidivism. So first would be, we have to reduce the prevalence rates of mental illness and substance use disorders in jails and prisons. I think honestly, this is one of the easiest things that you can do locally, and go to every meeting that you can and say, hey, what is the prevalence rate of mental illness in our jail? Maybe your sheriff says, well, it's 56%. Well, that shouldn't seem acceptable, should it, when that's not the prevalence rate in the community? In the community, we know it's somewhere between 4 to 5%. What's going on? That's an easy number where you can talk about what needs to be done and where are investments taking place in your community to try to address that significant disparity with the concentration of people with mental illness in the jails, not so much in the community. We obviously can't do these things. Whoops, someone's speaking. Can I keep talking on that slide? Sorry. We can't do these things if we don't increase our use of data and data-driven practices. The example that I just gave you is obviously around data. I think data on any issue, and this issue in particular that people have a lot of misconceptions, is really helpful in telling an accurate story, but we don't have enough of it. I think also cross-training criminal justice and behavioral health personnel, which is really a role that NAMI could play in bringing together your local partners on the criminal justice and behavioral health side to work together. And then, of course, always supporting community-based programs that prioritize individuals with complex needs. So not just provide behavioral health services, but you have to provide housing and employment services that work. Next slide. So these are some concrete recommendations we've made in recent years. We are huge fans of using community health workers and peers to support people with individuals with complex needs. We need to do more to hire people with former incarceration into our system of care for our peer providers. And we're very excited to continue to work on that. I know you had the Department of State Hospitals here a little bit earlier, but we really want to promote statewide broad implementation of pretrial diversion, and is going to be an essential tool in COVID-19 recovery. We also want to make sure people are educated about SB 389, and that's the bill that passed that lifted the ban on parolees for access to Mental Health Services Act funded programs. And then lastly, it doesn't do a lot of good to treat people and treat their mental health issues while they're incarcerated if you don't put the same investment in their reentry and transition home. So there's giving someone 20 bucks and saying, see you later, or I guess it's 200 bucks at the gate, see you later, good luck. That's not going to work for individuals with mental health challenges, and that's just not effective reentry practices. So what's on the horizon, I think, was coming up next.
Stephanie, I just wanted to give you a quick time check. It's 2:45, so I know we still have a few slides to move through, but just wanted to let you know.
Perfect, great, thank you. Okay, next slide. So we have a rapidly changing environment, and this is really what I wanted to talk about before we launch into questions and discussions. These are not small numbers. For one, this talks about our active cases inside CDCR, but I think what I would also share, obviously they've gone up dramatically as myself and many people who work at CDCR no longer sleep, but they've gone up dramatically. It's really aligned with the communities that have also have COVID hotspots. We have a lot of prisons in those areas, and I'm sure, as you all can imagine, they're related. Next slide. So these are not small numbers. We're talking big numbers. Over 12,000 people have been released from state prisons since March. And I'm assuming, while I live in it, I think it's not necessarily common knowledge. We have another 8,000 who could be released by the end of August. And if we think about the numbers we shared before, that somewhere around 30-ish% have an identified mental health treatment need in our general population, or just on average, and 70% have a substance use treatment need, we know the number of people coming home from state prison are going to need our services from our behavioral health system. The jail population is not all that much different. It's smaller in general, but again, over almost 30% reduction in the average daily rate totals. So that is just a significantly fewer amount of people who are in jail, and they're not getting booked, they're getting released early, they've served their time, they've earned their time, etc. But again, significant reductions, and these people are now in our communities. Next slide. This is being mirrored at the juvenile detention side of things. And I think a finding that Sharon from my staff found that we've been talking about is that closing schools and that whole kind of concept of the school to prison pipeline really probably does have something to do with these reduced school referrals. And school referrals have historically been the main source of disproportionate minority contact with the juvenile justice system. So I think this really warrants, again, while COVID's very negative, an opportunity to do the right thing and make some significant changes. Next slide. So we're also in a fiscal crisis, and I don't want to, I'm going to go through these slides fast because I just think you guys probably have been in other rooms where you've talked about the fiscal crisis. I think to sum it up, there's a commitment to try not to expose or make more vulnerable populations that are vulnerable. So people who need economic support or income supports, people who have complex health issues, they need their health care. We know that caseloads for the Medi-Cal program are going to skyrocket because of unemployment, things like that. And there were some other, fun tricks in terms of borrowing, etc. But there was no room for expanding and providing new programs. And many of us were all excited to work on some of those programs at the beginning of the year. Times have changed. Next slide. I think these might be some of the ones that I popped through. There are some silver linings. There was an acknowledgement that we need behavioral health counselors and emergency departments, that we need help with enrolling people into Medi-Cal, and really not tearing apart our health safety net. So that was good. Next slide. There also was some realignment backfill provided for counties, which you all know is very important so that we have money in our behavioral health sub-account. But again, it's not enough. It's not going to be enough. The administration continues to support local governments with resources to address the needs around the homeless. But again, I don't know about you, but I continue to see increasing numbers of homeless people, at least in my community, even despite these additional resources. Next slide. We also had a strange mix of public safety programs being preserved and eliminated. I think most importantly for us as a council and for the populations that we care about, the Integrated Services for Mentally Ill Parolee program was eliminated. As you see here, it still only was serving a very small set of our mentally ill parolee population, but it was pretty cost efficient. And these are now individuals, this 1,500 who are served annually, who will have to be served by the local system, by our local county behavioral health system. Action was deferred on eliminating our parole outpatient clinics, which provide case management services to people with mental health issues who are on parole. We don't know what that means, but we also do know that there's a strong emphasis that those individuals need to be integrated into the existing behavioral health system. Good news is that there were some restored funds for adult reentry grants that will help with housing and more handoff services, as well as some recent CARES money that was passed through to CDCR to provide emergency housing for expedited releases. Next slide. We also are faced with something that, you know, has been an issue that we've all needed to address for decades, but there's a momentum that I think is really going to be an opportunity to make significant change, and that is the racial justice movement. And it has been so exposed by how incredibly uniquely and acutely it is affecting populations that are returning from incarceration. And I think these things are colliding in hopefully an opportunity to really examine why so many populations are overrepresented in communities of color, but other marginalized groups. We mentioned the LGBTQ before, that are overrepresented in incarceration, and how can we really incorporate this time appropriately and make it part of our agenda for change. Next slide. So on the horizon, things that I think you guys are aware of, but I'm going to also go through these quickly so we can get to questions. But the Department of State Hospital was here a few weeks ago. We provide training and technical assistance to the counties and their partners who are implementing the felony pretrial diversion program, and also just generally speaking, training for counties to try to really have better services that target somebody who is being most at risk of being deemed incompetent to stand trial. Next slide, and there's information about this project and those trainings, which might be of interest to you on our website. We also are getting ready to launch, or in the middle of launching, our Lived Experience project, and we received money from the Mental Health Services Act to develop contracts for people to do local stakeholder advocacy. And the goal really here is really to build a bridge between the criminal justice and behavioral health partners, so that people are looking at ways in which access to behavioral health care and increasing that access through capacity building, outreach, awareness, education, has a direct link to reducing incarceration. So we're super excited about getting that off the ground. We've been a little bit delayed because of COVID-19, but very excited to move that forward and work with all of you in that process. Next slide. So these are the things that I kind of want to pose as questions. I mean, obviously you guys can ask me whatever questions you want and I'll do my best to answer, but this is what my council is grappling with right now and where we're focused. And so we had all these people who were released from jail and or they just weren't charged or booked, which is good. So what are we going to do to make sure that they don't end up back there? And how can we endure this public health and fiscal crisis without further marginalizing these groups? And so these are the two questions we're grappling with this year and developing policy recommendations around. Next. So we want you to be engaged in that process, and we want you to join us. Here is information about our structure and how you can plug yourself in if you want to be involved at the state level. Our council meetings are listed up there. Everything will be Zoom or WebEx or accessible to all of you, which is what's kind of super exciting about this process. Another, you know, one or two nice things about COVID-19. We have a reentry and reintegration work group, prevention and diversion and juvenile justice. Here's all the times. If you go to our website, you can also get all of the information about how to call in. And the next slide, I believe, next slide. Yes. It has my information if you want to send me a particular question that we don't get to today. And also you can sign up for our newsletter at that website link. And that'll give you all, it's really our listserv. So whenever we have a meeting or information about how to join a meeting or how to weigh in on a product that we're working on, you can do it in that way. So this is when I stop yammering and I turn it back to Angela so we can have some questions.
Well, thank you. I know that you went through a ton of information really quickly. And for those that joined us on the DISH call 2 weeks ago, I know that they also provided a ton of information, and we didn't actually get to a lot of the Q&A. And so for those of you that are waiting as a follow-up, I am still working with their communications team to gather the information for the questions that many of you sent in and post in the chat box. So I thank you for your patience on that. And just wanted to let you know that when Stephanie and I talked about this event, it was really important that we made sure that there was time for a conversation with you all today. So there's a lot of stuff going on in the chat box. If I don't get to your questions, and as they come in, sometimes they start to pile up. I promise I will pull all of these questions together, and I'll work with Stephanie and her team, and we'll get that information out to you. And as I'm scrolling here, I also wanted to mention the information that's shared here in the chat box. There's a lot of you that have shared links to information in your local communities. There were some links that were shared in the slides. I'll make sure that all of that is part of our follow-up, including the information here on how to connect with Stephanie and her team and sign up for their newsletter and get information on their dates and their meetings as well. So let's see, there's so much in here. Let's see, I'm going to grab this one that's right in front of me. So it says, the criminal justice data seems to be the same over the years. How many more studies are needed? The number of people ending up in jail and prison has not changed. The questions not asked are what happened, what services did not work, were not available prior to the crisis that caused the arrest. People who, people who are well in recovery don't end up in jail. People in crisis deemed to break the law while symptomatic end up in jail and prison. Is there such a study?
That's a big question. I think I would first, I want to agree with the author of that question that it's not like anything that I presented is new. I think most of us really see the trans institutionalization of people from the deinstitutionalization process in the 60s, and then the unfunded community mental health system in the 70s and 80s that basically led to, in conjunction with the high rates and tough on crime environment of the 90s, significantly high populations of people with mental illness in the jails. I think the one thing that I would say that I'm probably concerned about, though, and just what I've been able to witness, is that the concentration is increasing, especially amongst our young people. Most kids, young people who are in detention are really oftentimes there because there's nowhere else for them to go because they have such a significant mental health challenge and they can't find a placement. So I think to answer the second part of your question, is there such a study? I know that, we're committed to trying to provide information, but something that I would encourage you all to do locally is to kind of go back and ask, whether it's at or through your mental health board or through your community correctional partnership, and say, hey, are you producing regular dashboards to show us how many people with mental health issues are incarcerated, on probation? Parole would be a different place to go, but I think that's something that your county really needs to produce for you. The other thing about data that I always do a little bit of, not pushback on, but I'm a social worker by training, and people always say, oh, it's hard for engagement sometimes to ask certain questions, or we don't want to ask if somebody's involved in the criminal justice system because what does it matter? Well, for me, it matters because if you don't count them, then we don't know that they're either getting or not getting services. And I actually think, in working with people who are formerly incarcerated, who are quite savvy, that they wouldn't be offended if you asked that question. In many cases, they feel like the experience of incarceration has made them the person that they are. So I think it's really important when we collect data, that we ask people what their justice status is and to do it thoughtfully, so that we can also hold systems accountable who may be responsible for still helping those people. So if people are on probation or they're on parole in their community, but they're not getting any services, then we need to go back and think about what is parole and probation doing, or what should they be doing to contribute and add to the available services in the community.
Awesome. Okay, thank you. We've got another one here. It says, what is the CCJBH doing to decriminalize mental illness? For example, use of a medical rather than a police transport statewide. This alone would reduce trauma associated with an intake.
Yeah, excellent suggestion. One of our council members she's a deputy DA from Los Angeles, has been a huge advocate for I don't remember the bill numbers, but this has come up several times. And while we answer to the administration and advise the legislature, we can't actually, we can't officially, I guess, weigh in on legislation. But what we can do is really make sure that these are things that we can draw a line back to for best practices. And so a lot of times when bills are brought to our attention, we try to look at them and think through, well, could we provide a study or any information that would show that this piece of legislation is actually a best practice or would lead to a best practice? And so that's kind of some of what our role is when it comes to the policy arena, is really helping advocates like you make the case for those kinds of bills. So we're always interested. You can always send us ideas about bills that or policy changes that should be put in place. And we can also do some of the background research to try to make the case for that. But for whoever asked that question, I would absolutely agree. I'm a huge proponent, and I think people on our council would definitely agree with me that law enforcement should not be the front lines in crisis response.
Thank you. Let's see, next question. Is there a felony diversion court operating in California? Similar to, it says Miami has one.
Yeah, so we have several. The pilot that I spoke about is specific to felony pretrial. And so we have about, they presented on this before, I think we have 20 participating counties. I think about 5 of them are up and operational and diverting people. So the Miami-Dade model is an excellent model. I particularly like the idea that we're really moving towards pretrial diversion. So the goal is that we do not want people to be in jail at all. We want them to immediately be assessed for a diversion program and not necessarily have to go through the process of adjudication and also even potentially fleeing. And so, yes, those are definitely available, and we can work to get more information for that person if they're interested. I don't know what county they're in, and to see if they're interested in reaching out to a point of contact in their county that might be in charge of that.
Wonderful. I'll definitely make sure one of the things we work on in the wrap up, I'll get information for them on that. Let's see. Next question, how a family member can advocate for a mental health diversion plan in court, who to contact, public defender. They're asking, they live in San Diego County. Mm-hmm. And it says also keeping in mind that no one is in the courthouse here, everything is through audio and video.
Yeah, well, certainly going through the public defender's office is the best way to go. I can't speak intelligibly about every county's process by any means, but I do know that this is something that has been very frustrating for all sorts of people, but certainly family members, that there really is really impacted. I was in a meeting this morning talking to a public defender who basically said the reason why we need to move to things like pretrial is because the court aspect of doing things is so time consuming and costly that we can't serve as many people. So there have been some really, New York State is one of the states that has some really creative processes in place so that people can immediately get assessed and referred, and using peers for engagement in that process. So they're actually, criminal justice continues to play less and less of a role when it comes to behavioral health criminal justice collaborations. It's a big money saver, and more people can be served. That being said, for this person in San Diego County, we can do a little bit of follow-up if there's, I might be able to get you, like, at least we know the public defenders down there. But yeah, it's really hard. I mean, speaking of the Mental Health Services Act, which I like to bring up, but the Mental Health Services Act, one of the programs that was mentioned that should be funded with Mental Health Services Act dollars in the actual statute was something called the Mentally Ill Offender Crime Reduction Grant, which basically was a categorical funding source to pay for behavioral health courts. And so I would also kind of challenge back to all of you in your advocacy to go to your director, your mental health director, or whoever's leading the MHSA stakeholder process and say, hey, you know, how is the MHSA supporting diversion? Are we using any of our MHSA dollars to support the courts to expand the slots that they have for diversion? And I think, you know, that's really challenging because the courts and our criminal justice partners have a critical role to play in diversion, but it's not like that's Medi-Cal reimbursable. It takes money. So I think that that's also another legitimate question to ask locally.
Great, thank you. And then here, next one is, what are the top 3 charges that land a juvenile into the criminal justice system?
Ooh, what a good question. I do not know. I don't want to put Sharon on the, I don't even know if she's still on the phone. I am not very, my weak spot is juvenile justice policy. I don't know the answer to that, but it would be a good exercise for us to research it. I don't know, Sharon, do you have any thoughts on that? Because there's the juvenile justice system and there's detention, and there are 90% of the people who are in the juvenile justice system are, you know, not incarcerated. They haven't been put in juvenile hall. So I don't know. Sharon, do you have any thoughts on this, if you're there?
I didn't see her name on the list.
Okay.
And again, I mean, you know, we often kind of in these, you know, when we touch base before these, and as, you know, we've talked with you all, even for the folks that are joining us, you know, there's often going to be questions that are great that, you know, we may not necessarily have information. So that's why we try to pull everything together and get that in. So I'm just going to kind of go through, and, you know, we've had it in previous conversations where it's like, that's a really great question, and we're definitely going to have to pull some information together. So, but I do think that, you know, bringing them up, you know, kind of gets, I think sometimes people will have similar questions that they want to ask too. So let's see. What's the next one? Okay. Oh, here we go. As a high school student, what are some ways my peers and I can actively advocate for policy changes and bills that should be put into place? Any and all ideas are appreciated. Thank you so much for this information.
Oh, good question. As a high school student, well, I mean, I would kind of go back to that slide. I mean, it's an emerging area, but I'll speak for my local community and my local school district that there's really a re-examination of the role of school officers, school police officers. When I was a kid growing up, and I won't tell you how long ago it was, but it seems like a long time ago these days, we had school nurses and we had school counselors and we had social workers. I do think that we had somebody who locked in the parking lot, and so it's not like there was not a public safety officer of some sort, but I do think it has dramatically changed, and I think that that is something would be a tremendous asset to gather the perspectives of your peers, including their own personal interactions with a resource teacher, or maybe not being able to have access to a school counselor. And to do some sort of analysis and to really weigh in on that issue. I think it's going to be a critical issue in the year to come.
Perfect, thank you. Let's see. There's some really good comments. Folks are also talking, so I'm trying to make sure I'm grabbing that in here. Another question, I think it would be helpful to know what county data has to be reported to the state agencies. This would help us get better data locally. It's very difficult to get data from county departments, and state associations do not seem to report county by county.
Yeah, I think the thing I would say about this, and we can do a little bit of teasing that out, but high quality data from the jails is difficult. I think a lot of people would say that there's a lot of challenges with that data being accurate. But if you continue to advocate for it, you still can always have good local data. That's something that you really have control over. And if you have a probation chief who's committed to evidence-based practices, he or she is going to need good data. We have a former police chief on our council who was probation chief, who was the probation chief in San Diego County for a long time. And he would probably come on and give you an hour-long lecture about how it is the role of the probation chief to collect that data and to share it back with his various different task force, including the CCP. I think the other thing I think that we don't do enough of, I know the OAC is taking a look at it, but one of the unintended outcomes associated with undertreated or untreated mental illness is incarceration. And so counties with their full service partnerships are supposed to, even if it's just self-reported, but are supposed to report on how full service partnerships are contributing to a reduction in jail population. And so that's something that is also controlled locally. And again, I would encourage you to check in with your county and see if that's something that the county reports back out in any kind of structured way, because again, the Mental Health Services Act, one of its intents was to reduce incarceration amongst the population with mental illness. So I think that would be something that at the local level, your county should be reporting out to you.
Thank you. And then we did have a follow-up question. So we had the question about children. So I do want to throw it out, and we can also gather this after too, if it requires a little bit of research. But the top 3 reasons for adults entering the criminal justice system.
Let's see. And are you talking about adults with mental illness? I don't know if I would know adults generally. I mean, I don't quote me on this because I think we should do some more research. But if we're going to focus on jails instead of prisons, because that's very different, right? So people who are, okay, yes, adults with mental illness. I think at the local level for jails, there have been studies that do show that people are basically committing crimes of poverty. They're committing crimes to support their addiction, and they are engaged in behavior that we, or I don't want to label us, but that the general population finds threatening, frankly. The gentleman on the street who's not taking his medication and he's actively psychotic, and he decides to start throwing things at the cars that are driving by. I think one of the things that we see that's very frustrating, getting back to the issue of crisis response, is that, I mean, I know how I would respond if I was approached by the police and I was in crisis. It puts up your defense mechanisms, and I think for many people who are under extreme stress and may also be, dealing with some significant symptoms, they try to protect themselves, frankly. And if you get in a situation where you assault an officer, whether it's self-defense or not, or you resist arrest, that's just a major upcharge. And that's the kind of, you may just have been loitering originally or littering or whatever it is, but that interaction can really escalate and lead to a felony crime. So I hope that answers a little bit, but we can probably, I bet people have done that study. That's not a difficult study to do. But I think from my experience, those are kind of some of the things.
Thank you. Let's see. Our county is utilizing the Stepping Up initiative to address intercept mapping, stats in the jail, stakeholder involvement. Is this common? I know that you did touch on that initiative briefly.
Yeah, so kudos for your county. That's great, especially looking at ways in which you can measure your impact in each of those intercepts, because there are ways to do that. The one I always bring up is just the simple one, like, why are there so many people in jail? That's a really easy thing to measure. You can also very easily measure through that process how quickly, hopefully not quickly, but hopefully not at all, people who were in jail return to jail, and what kinds of county services, because you can control some of this stuff locally. You can get at your sheriff's data. I know people think it's impossible to exchange criminal justice and health data, but it can be done. And I think those are data sharing agreements and releases of information that are starting to be developed at the local level. In order for diversion to work, frankly, we have to be able to have those releases of information and ability to share data between criminal justice and health partners. That is, I'm not sure if I'm answering the question, but I think it's great that you're doing that. I believe that there are over 30 counties in California that have done or some aspect of that. I think some counties are deep into it. They have incorporated sequential intercept mapping maybe into their MHSA planning process, or their, you know, there are all sorts of funding streams that we haven't talked about, but, you know, Prop 47, quite frankly, Prop 64, doesn't just have to be Prop 63. We have our AB 109 funds, and then our funds for services that come through state administrations like Medi-Cal. So there are a variety of ways to pay for some of these things. And I think that's kind of where a lot of counties are doing some work in this area. And I do think that there are opportunities for counties, at least they're trying to facilitate cross-learning for county administrators, so that if San Joaquin County, for example, has really learned a cool practice associated with trying to operationalize or implement their sequential intercept mapping process, that's being shared with their sister county down in Stanislaus, for example. And I think we need to do more of that. And I think the OAC has maybe an initiative where they're trying to do that, especially around data. So.
Great, thank you. And then this one, I know that you touched briefly on the origins of the council. The question here was specific to whether the council came out of the legislation that was related to the Little Hoover Commission report.
Oh, you know, potentially. I think I'm not totally certain, but there was a lot of stuff that happened between 99 and 2001. I think 99 technically was when our when our council was introduced as a piece of legislation, and it was really to further the MIOCRA grants that I mentioned earlier. That was a pilot, but what was required in that pilot for those mentally ill offender crime reduction grants, which I believe those grants might have been the result of a Little Hoover Commission, as well as potentially the, report from the Little Hoover Commission. That predates me just barely. I started working in this field in 1999, so I missed it. But the idea is that in order for those grants to be successful, you needed to have the behavioral health court present, you needed to have the probation chief, you needed to have behavioral health director, you needed to have advocates like yourselves. And so they basically created a council at the state level that would bring all those partnerships together. So I didn't go into some of the details, but my council is chaired by the Secretary of CDCR, because ultimately all of us have failed at doing this work if someone ends up at CDCR, and also at the Department of State Hospitals, frankly. And so we have the Department of State Hospitals, CDCR, and the Department of Healthcare Services as kind of the administration representatives. And then the Attorney General's office has an appointee, the Chief Justice has an appointee, and so does the legislature in the Senate and the Assembly, with the idea that with all 12 people, we'll get all of the people that we need to have having a seat at the table to discuss these things. And when we changed our legislation and updated our statute to be inclusive of individuals with substance use disorders, so we changed our name to behavioral health rather than mentally ill offenders, there was an additional clause added that said that anybody who was appointed should be appointed, and that appointment take into consideration their lived experience. So I think the hope is that eventually we'll have a council that's made up of peers, family members, and other individuals who've experienced forms of incarceration or justice involvement, as well as the hat that they may wear as a, substance use provider or a juvenile justice advocate, etc. So you probably didn't want to know all that background, but I just gave it to you, sorry.
No, I appreciate that. I think, that's the whole meaning of Q&A is we're going to get all kinds of information and questions. So I know that we get a lot of feedback from the participants that it's just really nice to have space for an open dialogue with the different folks that have joined us. As you know, being in this field for a long time, many of the opportunities that advocates get are limited to 3-minute public comments that are tacked into an end of a meeting. And there's so many different custodial partners of the mental health system. And so really being able to kind of demystify, who's got a hand in which piece, and just being able to ask these questions has been incredibly helpful to our folks. And I know that, those that have participated, we get really great feedback on, just being able to have a casual dialogue. We have a couple more questions that we can throw out before we wrap up. Let me scroll back up here. There was a question about the list of counties in the Stepping Up initiative. We can grab that and share that in the follow-up materials. Another one here. So if my adult child with schizophrenia gets arrested again, is there an organization that would help to advocate or support before charges are filed? My experience is once the charges are filed, the ball is rolling and there is no stopping it.
Yeah. Before the charges are filed is tough. I'm honestly sorry to put this back on you guys, but there is not. I mean, I think that so this is one of the reasons why we wanted to do the Lived Experience Project, and we're glad that we have some MHSA funding is, you have these traditional criminal justice advocacy groups, and then we have our traditional mental health advocacy groups. We even have, advocacy groups for foster care kids and this, that, and the other. Is there a group or an organization that someone can go to with your very question? I don't necessarily think so. It doesn't mean that those other organizations haven't stepped in and tried to assist with that. But really, honestly, when I get parents who call me in distress because somebody is in, maybe they're in one of our state prison facilities and they don't know what to do. First, if this person was unfortunately in prison, there are staff assigned to each institutions who can work with you to get you the information that you need. And that's something that my office can assist you with. But in terms of preventing that and having the ability to have, say, like somebody help you locally to navigate and advocate for maybe that for your child to be placed in a behavioral health court, I don't really know of another entity other than I've wanted it to be NAMI for a long time. I do think sometimes, obviously the county, and I don't want to say this to every county, but usually your county mental health system is the provider, so to speak, the administrative provider for your behavioral health court. That is, if your child is part of that system or receiving those services, I mean, I think one of the things that, this is kind of a solution that doesn't require advocacy, but if we have the data and someone has signed a release of information, why couldn't we, if your son has been arrested multiple times and he's a current behavioral health client, why can't a list of people like that be flagged for the county behavioral health system who currently provides that person's services? I don't know if I was thinking that person was responding to what I was saying, but I think some of those creative ideas are kind of coming up as we explore the implementation of diversion, and especially in light of COVID as well. But, I think it was Santa Barbara County, and Santa Barbara County, don't quote me on this. I could be wrong. It might be Ventura, but there was a really strong relationship between the sheriff, the public defender, and the county behavioral health director. And there really was a list of those individuals who, quite frankly, were in that revolving door. And so as a smaller community, while it's not super small, it's small enough, those people could be identified, and the public defender got a list, and that list also was matched up to the county behavioral health list, where they knew, oh, this is Joe, and Joe's in this program. I think there are, if we have embedded staff in the jails, I think that those staff also could play, and I mean mental health staff, an important role working with clients and immediately getting in touch with their loved ones. But you all know that it's challenging if someone doesn't want help or doesn't want to reach out to a loved one, or maybe they don't want people to know that they've been, they've been picked up. But I think a lot of that, talking about criminal justice advance directives, I mean, I think there's some cool ideas out there. So that, I think it was you guys that brought this to my attention. We've been talking about it around advance directives in a lot of different ways, but I love the idea of the criminal justice one, if that's something that we can pilot and think through, so that the partners are empowered to stop the process before it gets too far down the road, if the person has, provided them a roadmap of what needs to happen if they get arrested.
Great, thank you. And then we've got time for one last question. Let's see. Since the DA controls charging, are there efforts to educate DAs like there are, or like there is, CIT for law enforcement?
Oh, that's a great suggestion. That's a great thing for NAMI to do. You all and your stories are way more powerful than my set of slides. And I really do, I mean, I don't know if this is the last question, but I wanted to make sure I made this point so I don't forget. I have approached this work as 50% research, thoughtful, analysis, and 50% the impact of people's real stories. And that's how we make change. And, I just, the DAs are not bad people. They're there to protect victims. They're there to ensure public safety. And so once you kind of think about it through that lens and approach it, that's why we always say that public health is a public safety issue. It is in their best interest, and many DAs are great leaders in this. They know that it's in their best interest to have a robust mental health system so that these individuals don't end up in their communities. But let's think more about that, because I would think, I think sometimes CIT needs to expand and is a little bit limiting. It's an awesome resource. It's like mental health first aid's not enough. CIT might be a little bit too much for really busy people like DAs, but I do think there's something there that would be really useful. And I think something that I've learned from our judges that we work with, and I was sharing this earlier today as well, them sharing with their peers the willingness to take a risk and potentially divert someone or recommend someone for diversion that they never would have been able to do, is really effective in changing the minds and attitudes of their peers. So when we've been doing a lot of training around diversion, we've really been doing it peer to peer. And I think that would be, partnering up with a DA champion, so to speak. And there are champions for this issues who are elected DAs in various different places. I'm thinking of Santa Clara is one, and it may not be the same DA that I interacted with years ago, but and going with them to talk to their peers, and you sharing your story and them sharing a story of how they took a risk and had a learning experience and provided leadership in this area on how to do the right thing.
Great. Well, I just want to say thank you so much for taking the time to chat with all of us today, carving out time to answer these questions. For those of you who are still adding questions, who have sent some over in email, we'll gather all those and we'll work with Stephanie's team to get answers. I think we've got a lot of great ideas here, and it sounds like there's a lot of opportunities for our local affiliates and members and family members to get involved in some of the things that you talked about today. So with that, I just really want to say thank you so much. And for those of you that are joining us today, we will have the materials as well as a link to this presentation available for you all. We'll also post it on our website at namica.org. I'm going to put into the chat box too a link for all of you for our upcoming schedule of town halls. We've got a few already scheduled, so just save the date for, we've got coming up next on August 11th is the Mental Health Services Oversight and Accountability Commission, also known as the OAC. We've got the California State Association of Counties, or CSAC, joining us on August 20th. Into September, on September 3rd, we have the Department of Managed Healthcare. September 15th, we have CPEN, the California Pan-Ethnic Health Network. And then on September 29th, we've got the California Alliance for Children and Family Services. So those are the ones that are coming up. I've put a link in the chat box. You can go in and get the links to join those as they come up. And we'll follow up with all of you, the questions, the materials, the slide deck. And in the meantime, if you have any questions, always feel free to reach out to any one of our staff members. My email address is angela@namica.org. You can always track me down that way. And so I wish all of you health and wellness, and we will see you for our next event. And I hope that you all have a wonderful day. Thank you.
Thanks, everyone.